hypoxia to the fetus. Okay, now we will continue with the gynecological investigation. So some of the common investigations that we use the hormone investigations like that of prolactin, TSH, FSH and LH, estrogen, progesterone, androgen, etc. So these are the common hormones that we are doing, hormone tests that we are doing. So one of the common hormone that we're doing is prolactin. The prolactin hormone is secreted from the anterior pituitary gland. So this hormone is responsible for the lactation in a, after postpartum period. So this then the physiological increase of prolactin hormone is essential for the normal lactation. So even also after exercise or even some stress also cause a physiological mild increase in prolactin level. Or certain medicines or certain drugs also cause an increase in the prolactin hormone level. So if a patient comes to you with galactoria, galactoria means the secretion of milk from the breast in a non-pregnant woman, if or a lady comes to you with a clinical presentation like galactoria or even oligomenorrhea, anovulation, like that you had to check the prolactin level. Or sometimes the patient come to you with the clinical symptom with, like as I had already mentioned, milk is coming from the breast. Otherwise, while doing an infertility evaluation, we are happen to see there is an increased level of prolactin hormone, especially greater than 20 nanogram per ml. So, if such a finding is that there is an increased prolactin level in her blood, so the next thing you had to check the TSH. Okay, TSH, thyroid stimulating hormone. If TSH is increased, okay, if TSH is increased, it may be the reason for increased prolactin level. So you had to manage the thyroid, you had to manage the TSH level, or you had to advise the thyroid drugs like thyroxine, etc. Otherwise, if the thyroxine, especially otherwise the if the TSH level is normal, then the next probable diagnosis will be because this prolactin hormone is secreted from the anterior pituitary. So the next probable diagnosis may be there is some like growth in the pituitary gland, which may be the reason for the increased prolactin level. So in 80 to 90% of case, there may be there may be increased TSH, may be reason for this increased prolactin level. So you had to check the TSH first, and later, if it is, I had already mentioned later that you can do an MRI. So the clinical presentations in if an thyroid function is abnormal, the clinical presentation may be oligomenorrhea, that is there may be more than 35 days, cycle interval may be more than 35 days, or even some patient may have amenorrhea, absence of menstruation or heavy bleeding or subfertility. Thyroid hormone is essential for the normal conception. Nowadays there are so many infertility cases associated with the hypothyroidism. So first you had to check TSH. In TSH, if it's high, then check T4 level. If T4 level is low, then it is hypothyroidism. If T4 level is normal and TSH level is high, it is said to be the subclinical hypothyroidism. If T4 and T3 level is high, it is hypothyroidism. So if a patient comes you with oligomenorrhea, definitely you had to check the thyroid functions also. Another this hormone test we are doing is FSH-LH. FSH in early follicular phase, especially FSH is done in the second or third day of menstruation. It is the most apt time to evaluate the FSH level. If FSH level is between 3 to 10, it is normal. If FSH level is greater than 20 or 25 international unit per liter, so it indicates that the ovary is not functioning. Like if a thyroid is not functioning, so the thyroid stimulating hormone is secreted more to stimulate this thyroid gland. Likewise, if FSH level is increased, so that it is stimulating more the ovary to function normally. So an increased FSH means increased FSH and LH means it indicates that the ovary function is not doing properly. So diminishing over, so AMH value is also checked. AMH hormone is evaluated on day 2 or day 3. In that, you will get a normal value of 2 to 4 nanogram per ml. If it is less than 2 nanogram per ml, we can assess that the ovarian function is low. If it is more than 4, it indicates that there is an increased risk of PCOS. Another test is the serum progesterone level. We are evaluating serum progesterone level in the mid-luteal phase. That is, in the first phase, there is follicular development. Up to 14 days, there is ovulation. After that, there is luteal phase. After ovulation to the next days from 14 to 28, this is the luteal phase. In the mid-luteal phase, due to ovulation, the progesterone level will be 5 to 20 nanogram. It indicates that there is a proper ovulation is done. Proper ovulation happened. So, moving to the USGs in gynecological disorders. We usually use a USG to assess the PCOS, endometriosis, endometriotic hyperplasia, or irregular bleeding, or with patients' complaints of fibroid, etc. So, first we will see what in about endometriosis. Endometriosis means the presence of functional endometrium outside the uterus. Endometrium is the inner lining of the uterus. So this inner lining, if present outside the uterus, is known as endometriosis. Even in the muscular layer, it can happen. Then it is known as adenomyosis. So, if a patient comes to you with a severe menstrual pain, that is, menstrual pain lasts for even starts 2 to 3 days prior to menstruation, or even during the menstruation, or even some patients may have even 2 or 3 days after menstruation, they have severe abdominal pain along with brownish discharge. So, the first thing came to your mind should be endometriosis. You should suspect endometriosis first. Then you do a UST to rule out your diagnosis. In a UST, if the most common site of developing endometriosis is the ovary. Ovary is the most common site. So while doing a UST, you can see that there will be a chocolate cyst or ovarian endometrioma. Sometimes you see that there was a clear cyst, or sometimes it may said that in the report may said that there is a cyst with low level echogenicity, or even there is multiple septation is seen in the cyst. All these are characteristics of this ovarian endometrioma. Sometimes with severe adhesion also, this ovary may be dislocated from its normal position. Sometimes the ovary may move from the a normal position to the even to the back of the uterus, so that sometimes there may be normal ovulation or normal ovum pickup by the fallopian tube is not possible. Or sometimes due to this endometriosis, hydrosalpinx, that is, fluid may fill in the fallopian tube. That is, hydrosalpinx is also commonly seen associated with this endometriosis. In this report, you can see this is right ovarian cyst. One most common finding is that in most of the patients, almost 60% of patients, we can see that the endometrioma is seen on the left ovary. Or even sometimes you can see bilateral, that is, in both ovaries, you can see the endometriotic or chocolate cyst. Next common disease you will get in OPD, or that is PCOS, polycystic ovarian syndrome. So the common clinical presentation you may get is of irregular cycles, that there may be amenorrhea for 2 or 3 months, or there may be heavy bleeding. Like irregular cycles is one clinical presentation. Then next is hirsutism. You can see that patient may have increased hair growth on her face, neck, chest, etc. Like male pattern of hair, thick hair you can see. Another is acanthosis nigricans. That is, you can see pigmentation on the neck, which is a symbol or a sign of insulin resistance in her body. She may be in a verge of like a pre-diabetic stage, and anovulation or infertility, which are the common clinical presentation. So in such patients, you can do a USG to evaluate the ovary. Usually, you can see in a USG there is multiple follicles are seen in the ovary. Ovarian volume increases. Usually, ovarian volume is less than 10 cc. In PCOS patients, the ovarian volume increases from 10 to even 10 to 19 cc. The ovarian volume increases. So we can also do a USG to evaluate the progress of our treatment. Another common investigation we usually do is on fibroid uterus. If a patient complains to you with irregular bleeding or heavy bleeding during menstruation, we can suspect the fibroid. The chance of fibroid is there. So fibroid are benign growth. It can be seen. It is originated from the muscular origin. If a fibroid occurs near the endometrium, this is the endometrium. If this occur near this endometrium, then it is known as submucosal fibroid. If this between this muscular light is known as intramural, or it close to the peritoneum, it is known as subserosal. Okay, inside near to the endometrium, it is submucosal, intramural, and subserosal. So this is an ultrasonographic image. This is a uterus. You can see this endometrium. You can see this fibroid. This is a submucous fibroid is getting into the endometrial cavity, which may be a reason for heavy bleeding for this patient. And also, if pregnancy is planning, this itself may be a cause for infertility. Or if this fibroid occurs near the corner of uterus. Corner means where the fallopian tube attached to the uterus. So this is the corner. If it occurs around or nearby the corner of uterus, there may be a more chance of ectopic pregnancy. So if there is a submucosal large fibroid is there, it is always advisable to do or to advise a myomectomy, to removal of this myoma or fibroid if pregnancy is planning or if severe bleeding is there. Next is antral follicular count. Antral follicular means a follicle of size 2 to 10 millimeter. Especially this antral follicular count is done during the second or third day of menstruation. So this is evaluated mainly through transvaginal sonography. And we can say that almost 5 to 10 antral follicle is present in an ovary around the second or third day of the cycle. So if the level is less than say about 8 or say about 5, then it is considered to be a poor reserve. If the antral follicle number is more than 10, then we can suspect a PCOS. So this AFC value is attaining more, especially nowadays IVF treatments are more. So this AFC usually is measured in the IVF centers, and patients sometimes approach to you claiming that they have low AFC or low AMH. Next is a follicular study, which help to evaluate the ovulation or not. So it also helps to evaluate the proper flow follicular growth. Follicle means an antral follicle, the small follicle. We can assess ultrasonographically the growth of follicle when the follicle reach almost 20 millimeter. Okay, when it reaches a number of say about 20 millimeter, there is more chance of rupturing of the follicle and ovulation happen. So we are assessing the follicular growth from 10th day, and alternate days we are advised to do an USG till the ovulation is observed. And after ovulation also, you can see the either there may be a dominant follicle is seen in either whether it is in a right or left ovary, and the doctor is assessing the follicular size like 12 into 15 millimeter, like that up to 20 millimeter. When it reaches, the ovulation happens, and as a sign of ovulation, this follicular fluid is present in the pouch of Douglas. Pouch of Douglas is the area behind to this uterus, that is the pouch of Douglas. In the pouch of Douglas is the most dependent area. So this follicular fluid may easily collected in the pouch of Douglas. It is also a sign of ovulation. one of the most common examination that we do in our OPD is a pelvic examination. So if a lady is either married or if she is sexually active, you can easily do a pelvic examination. So when a patient after emptying her bladder, we place her in a lithotomic position. Then either by first you can do a bimanual examination. Bimanual examination means using both hands. First two fingers that is inserted into the vagina. There you can feel the lower portion of the uterus or the cervix. You can feel it, the lower portion of the uterus, and you can assess whether the cervix is in upward or a downward direction, or whether the uterus is a retroverted or anteverted position. You can assess with the position of the cervix. Then you can do a cervical motion tenderness test like this. This is the cervix. I had inserted my two fingers in the vagina and I move the cervix a little bit. So if the patient had pain while moving, that is cervical motion or tenderness test is positive. So that there is some sort of infection. That is why the patient have this tenderness or pain. Most probably the patient may feel the movement, not pain. They can feel the movement but not pain. If pain is there, there is some sort of infection or pelvic inflammatory disease is there. Next, after this vagina, and I am seeing the cervix like this. After that, I am looking the fornix, whether the fornixes are free. That is the area around the cervix, the posterior side, anterior side, lateral side. I am looking whether the fornixes are free or not. In the lateral fornixes, I can feel the ovary. My abdominal hand, when I using my abdominal hand on the uh, iliac fossa, around that region, that here in this here, and I'm using my abdominal hand kept over here and my vaginal hand over here. I can easily, if a patient is thin, I can easily feel the ovary in between. Like that, on both sides, you can easily feel if the patient is lean. That is a bimanual examination. After that, you are assessing the position of the cervix. Now you can insert a Cusco's bivalve speculum. This is a Cusco's bivalve speculum. After making this mouth close, we can insert this speculum into the vagina, and then by pressing these two portions together, then the mouth will get open. When the mouth gets open, I had to screw it so that it will open and it will retain its position, so that my both hands will be free and I can take instruments or I can do wiping, all those. Then this position, then this cuscus will stay in position. So after that, we can, this is a view of cuscus. This is a cuscus. uh, I had inserted a cuscus there. You can see the cervix. This is a cervix with infection. So this is a normal cervix. You can see a cervix like this with normal cervix. Okay. This is a patient with severe infection. You can still see there is secretion coming from os. This is the internal os. Sorry, this is the external os. You can see secretion is coming from the os. So there is some infection there. There is cervicitis. This is the cervix, and there is infection and inflammation. So there is cervicitis is present in this patient. Here also you can see an angry looking cervix that you can see. Okay, in this type of patient, this we can look for infection, and if infection is present, we can give medicine internally, or even if we can do a retained douche or a local douche. Retained douche, I have got more result than a local douche. Like that, after putting a cuscos, either using a tribala kashaya or a nalpamaradi kashaya, I'm retaining the medicine there for 2 minutes. Then after removing that, then again second set of medicine is using. In such type of retained douche, more effect is getting than a normal douche. So if a patient is having this patient, the cervix is not feeling healthy, so it is advised to do a pap smear. Pap smear means the cervix, I'm taking cells, especially cells from this squamocolumnar junction, and I'm doing a cytological evaluation. Cytology means the cells in the particular area is studied for any abnormality or any premalignant lesion like that. So after inserting cuscos, a pap smear is done. After that, I'm inserting These are three types of brush which we are commonly using. This is a cyto brush. If I want a sample from this inner portion, especially this endocervix, I am using this type of brush. If I want sample from this area, both the squamocolumnar junction and also some inner tissue, I am using this type of brush because this portion I have inserted into the opening of cervix, and I will rotate the brush into 360 degree, so I will get enough sample. One more thing you have to be careful that before taking a sample, please do not wipe or you do not use any reagents or on the cervix. You had to take it plainly. So the sample is taken, and please make sure that this top does not touch any of the surface. And after that, this portion, this broom is removed, and it is placed in the liquid, that is acetic acid, 90% acetic acid liquid, and it is sent for cytological evaluation. Is it clear? Okay, now the report will be either there is a normal study, or even there is some mild change result, that is cervical intraepithelial neoplasia. There is some mild or moderate change in the pattern of cells, or even there may be a HPV infection, human papilloma viral infection. Is there such type of reports it may come? So depending upon that, we can treat accordingly. So it is mainly used to screen cervical cancer. We are suspecting that this case is having some abnormality in the cervical tissue. So this patient may have a probable chance of developing into cervical malignancy or cervical atypia. So such type of patient screening is done by this PAP screen. It is now commonly done. So you had to understand this properly. Another the next step of this PAPS evaluation is colposcopic evaluation. So when the report it mentions that there is some atypia or some abnormality in the tissue. So my next step is to do a colposcopic evaluation. Colposcopy means it's like a microscope, like a binocular, which has more resolution, which has more zooming power, like 10 to 20 times more zooming power. So if a pap test is positive, we can do a colposcopic evaluation. This is a colposcope. By placing a patient in the thoracic position, and after inserting the cuscos, opening the cervix, we are visualizing the cervix with the microscope, binocular, like binocular type of microscope. We are visualizing the cervix. Another, we are using it visualizing under acetic acid, that is visual inspection with acetovitamin or acetic acid applying. We can apply 3 to 5% of acetic acid on the cervix with a sponge holding forceps. We are painting the cervix with this acetic acid. So in such case, if the abnormal cells or tissue is present in the cervix, it turn white, that is acetovitamin. So it will be easy to take biopsy from that particular area. Otherwise, we are doing a Schiller's iodine or Lugos iodine. We are painting the cervix with iodine. So the normal tissue will absorb the iodine. Iodine color, you all know, no? It's almost like a brown color. The normal tissue will absorb the color. The abnormal tissue will not absorb. So you had to take biopsy from that particular area using either a punch biopsy forceps. You can take that particular sample from that particular area. You can do a test for either premalignancy or malignancy. Another common investigation which is done is a hysterosalpingography. Especially it is done in association with infertility management. We can see that it's a radiological procedure. That is, by after the patient is kept in lithotomy position, after inserting cuscos, by using a Rubin's cannula, you are injecting a dye. This dye is a water soluble dye and radiopaque. It is because of this radiopaque we can get an X-ray image. Only because of this radio opaque dye we can get this beautiful image. So 10 to 15 ml is inserted through the cervical opening, and we will take first X-ray when the uterus is filled. We will take first X-ray so that we can see whether there is any abnormality, whether there is any congenital anomaly of this uterus. Then second X-ray is taken after the spillage. Okay, this when a dye is injected, where first the uterus will fill, then it will pass through the fallopian tube and it will flow out into the peritoneal area. So if the tube is patent or if the tube is open, definitely this dye will flow out. So this is mainly done for a tube patency test. Okay, one thing you had to keep in mind that this patient should not have any vaginal infection or acute pelvic inflammatory disease like that. Otherwise, we will spread this infection to peritoneum. Okay, first you had to check whether the patient is cervix and vagina is healthy. Then only you can suggest an hysterosalpingography. After doing a hysterosalpingography for 3 months, there is an increased chance of pregnancy. Okay, this is one of a clinical observation. Another test is common. This is also done as a part of infertility evaluation. This is a diagnostic laparoscopy. Diagnostic laparoscope, as we all know, it's a fiber optic instrument. After piercing this anterior abdominal wall, using a venosal needle, carbon dioxide is inserted so that the abdomen gets insufflated. Then, with the help of a trocar, another incision is made, and the incision is made here, or this, and the incision is made, and through that incision, a light source or a telescope is passed, so that you will get a view of the inside of the abdomen. This is a laparoscopic view. You can see a normal uterus with this white. This is a ovary, and this is a fallopian tube. This is the normal view of a peritoneum. So, and the pouch of Douglas, all are clear. All the membranes. Just look for all the findings. This mainly done to as a part of infertility evaluation, or also done as a part of treatment modality also. So this is a laparoscopic view of this is a normal endometrium. Normal image and laparoscopic image, and this is a laparoscopic image of an endometriotic pelvis. Okay, you can see the severe endometriotic deposit is there. In the ovary also you can see this endometrioma. Okay, these are two endometriomas and severe adhesions in the pouch of Douglas. This patient may definitely have dyspareunia, that is pain during sexual intercourse, or even severe pain during menstruation. This is a laparoscopic chromoperturbation, that is with the help of laparoscopy. That is the laparoscopic view with this. Another, the patient dye is injected through the cervix, and with the dye is injected, with the laparoscopic view itself, you can see the dye passes through the fallopian tube and it falls in the peritoneum. We can view that. That is the laparoscopic chromoperturbation. Like this blue dye is injected, and this dye usually absorbs within 3 to 4 hours. Sometimes the patient may, if they're doing like an HST, sometimes the patient may have mild abdominal discomfort or cramping may be seen, but usually this dye gets absorbed in 3 to 4 hours. And the investigation is hysteroscopy. Hysteroscopy, like laparoscopy, the hysteroscope, the instrument is passed inside through the cervix. Like after lithotomy position, after cuscos is inserted, then this hysteroscope is passed inside the cervical opening, and a distension media is used, like carbon dioxide or normal saline, like a distension media is inserted. Okay, after the insertion of media, you can see for whether there is any abnormality inside the uterus. Like this is a normal view. You can see the openings or the ostium where the fallopian tube is attached. There is no fibroid, no polyp, nothing like that. In this case, you can see the fibroid, etc. So With hysteroscopy is usually done if there is a suspected case of septum. That is whether septum is present in the uterus or polyp is present in the uterus. With the hysteroscope, along with the hysteroscopy, they will do as a curative also. They will remove the septum also. So this procedure can be used as a screening method or also as a therapeutic means they can use. So endometrial biopsy or endometrial sampling, we are taking in this the fuscus inserted and an endometrial sample is taken, that is from either from the like a scraping is done both from the anterior abdominal, posterior abdominal, anterior uterine surface or anterior, posterior, both lateral. Or from these four areas samples are collected and they are evaluated, especially done in postmenopausal bleeding. That is, even after menopause, there is bleeding. There may be chance of this endometrial hyperplasia or endometrial CA. To evaluate that also, we can use this endometrial biopsy, or even patient with abnormal uterine bleeding, they also we can do this endometrial biopsy. Another common is CA125 tumor marker. Tumor markers evaluated for any ovarian tumor, or even CA125 is increased in patients with endometriosis. In endometriosis patients, the CA125 may be much increased than the normal value. So it's also marker we can use in the endometriosis and also ovarian CA. So some of the common, next is the breast tissues. Some of the common breast disease you may get in your OPD, maybe the patient may complain of a lump in the breast, or there may be pain, or there may be discharge like bloodish or yellowish discharge from the nipple, or even some redness in the. So it is always advised to do a screening test, either do a mammogram or a breast USG. Or even if cyst is there, we can also do an fine needle aspiration also. If patient is of younger age, or if the patient is a pregnant or a lactating mother, we can do a breast USG. Then by this we can see whether there is a tumor or a cyst. Cyst is a fluid filled swelling. If a mass is present, we will assess the shape. If there is irregular shape, is always a sign of there is a possible chance of malignancy. And also the blood supply to the core of the tumor, if the more blood supply is there, then also it is a suspected malignancy. And microcalcification, there is a calcium deposition is seen in the tumor. These are some of the symptoms, or some of the observations, or some of the images that we get for if we are suspecting a malignancy. A mammogram is also a soft breast tissue imaging. It can detect, the best thing is it can detect a cancer even before a lump is felt. So it can detect even before that. It gets used either for screening purpose, like if there is a family history of breast disease. So like a routinely a woman can do a routine mammogram within every 2 years. Here also this margin, and if simple cyst is present, you can do a fine needle aspiration to do a cytological studies. So in moving to infertility evaluation. So in infertility evaluation, as I said, the case taking is important. We had to take case of both patients along the marital history, sexual history, the previous illness, especially if males are there, the history of moms like that. Everything we had to do a thorough history. So if the first and foremost test we had to do in a male infertility evaluation is a semen analysis. So we had to advise a semen analysis for after 2 to 3 days of abstinence. So after 2 to 3 days of abstinence, we will get a proper sample. We will evaluate for this a sample test. We will evaluate for the volume. If the volume is less than 2 ml, so that is not normal, then we can do a pH evaluation. Is there liquefaction? If liquefaction more than 30 minutes or 60 minutes is not normal, look for viscosity, total count, motility, okay, sperm agglutination is there, the progressive motility, morphology, all these factors should be looked for. So if in patients with Azoospermia. Some patients may complain with azoospermia, the absence of sperm. Such patients, we had to do an ultrasonographic scanning and also hormone assay like FSH, LHS, etc. Even testosterone and prolactin, depending upon the patient condition. And cervical factor, we can also assess the post cervical test, post coital test we can do to assess the anti-sperm antibody reaction between the with the mucous membrane. And also we can do assess the cervical mucus for bacteriological study. And then for a female we can do a follicular study to assess the ovulation. The first and foremost, you had to do a semen analysis. After you take the history that the patient is having a regular cycle, her cycles is regular, then assess ovulation by doing a follicular study. Further, if ovulation are normal, further we can do a tube test to assess the tubal patency, or even the cervical factor, or even you can do examination to look whether the cervical opening is patent, like there is a pinhole cervix is there. Or sometimes you had to ask whether the patient is having a regular sexual contact also. Sometimes the patient may come to you claiming that they are having this infertility issue. By if taking by case, we can see that the patient may have only may have sexual contact for once or twice in a month, but they have no, even they don't have any idea about the fertile period also. So you had to educate them also. You had to educate them also about the fertile period, etc. So here ends the gynecological evaluation. So these are some of the syllabus point that we covered. The diagnostic for PG students, the diagnostic techniques in gynecology, and the basic knowledge of pathological and biochemical investigation. For BMS students, antenatal investigation, investigations in fertility, etc. And non detailed about laparoscopy, hysteroscopy, hysterosalpingography, etc. Thank you for your patient listening. If any doubt, please ask.
Yeah, thank you, doctors. Thank you very much.
Thank you.
So I think some questions in the chat box there.
Okay.
So what's the method of evaluating the PMNL rate? How it is done?
PNML rate,
Hmm.
can you please specify it?
Yeah, it is asked by Dr. Ujita Suresh. Doctor, are you there? Okay. I think we can go to next session.
Okay.
Next question. Uh, wha- so, what indication of laparoscopic chromotubation?
Laparoscopic combotubation. Okay. I had already discussed about that. If by laparoscopy nowadays, because they are using for infertility evaluation, like if a patient, they both the couples are having they're normal, even though pregnancy is not happening, then a diagnostic laparoscopy is usually advised. For doing when doing this like diagnostic laparoscopy, they are also using this chromoperturbation to check the patency of the tube, so that all the factors are excluded for an infertility evaluation.
Yeah, participants can now unmute themselves and ask the questions. Okay. So asking about the AMH and its some details.
Okay, AMH level means AMH is anti-Mullerian hormone. Actually, the woman is having an ovarian reserve at the time of her birth. At the time of the birth, woman the ovary of a baby is having, especially the girl baby, in her ovary, the